Chapter 2. Homeostasis, Allostasis, and Adaptive Responses to Stressors. Humans, like all living organisms, must be able to respond and adapt to alterations in the environment. Changes in the external environment, such as moving outside from a warm house on a cold winter day, demand physiologic adjustments in the body's internal environment beyond the simple addition of layers of clothing to the outside of the body. Variations in the internal environment, such as a fever caused by infection, also necessitate physiologic responses to return the body's temperature to the normal range. The human organism maintains a variety of highly complex interactions with both internal and external environments. These interactions facilitate ongoing compensatory changes designed to support the organism physically and psychologically. Compensatory changes are necessary because they allow the perpetuation of both the individual and the species. Researchers, however, have found that the body's efforts to adapt to prolonged and repeated or extraordinarily demanding environmental changes may be associated with many physical and psychological health problems. This chapter explores the historical and current perspectives of homeostasis, allostasis, and stress responses and their relationship to health and illness. Homeostasis and allostasis. Homeostasis. The word homeostasis is derived from the Greek words homeo, or similar, and stasis, or standing still, and means maintaining internal conditions in a stable state by keeping parameters relatively the same. Homeostasis often is conceptualized as a state of being in which all systems are in balance around a particular ideal, set point. From this perspective, bodily changes formerly seen as conflicting or detrimental are understood as adaptive or compensatory to the maintenance of homeostasis within the body as a whole. Homeostasis reflects a tendency to stabilize an organism's functional systems, despite changes both internally and externally. Deviations from homeostasis resulting from these changes require elaborate systems to support the return of balance to the body. Over the past several decades, the definition of homeostasis has been criticized as being inadequate in encompassing the entire process of maintaining a stable state in complex organisms. But the fact remains that homeostatic concepts are an essential starting point for an exploration of stress, adaptation, and disease. Claude Bernard, a 19th-century French physiologist, is credited with describing the basic premise of homeostasis. He believed that the various vital physiologic mechanisms of the body had as their goal the maintenance of a uniform and constant internal environment, or milieu intérieur, for the body. The stability of the internal environment was deemed necessary for the survival of the person, independent or free of the external environment. Disease occurred when the body did not respond appropriately to maintain internal stability when threatened by perceived or actual events. Building on Bernard's work, Walter B. Cannon created a concept that he referred to as homeostasis in his 1932 book The Wisdom of the Body. Homeostasis, according to Cannon, was a process in which each of the body's biochemical or physiologic variables, e.g., body temperature, oxygen, sodium, calcium, and glucose levels, and pH, was maintained within a narrow set point range. Negative feedback loops sensed and corrected deviations from the set point ranges for the variables, thereby supporting the survival of the individual, despite threats from the external or internal environments. These environmental threats could range from temperature extremes and water loss or gain, to savage creatures and bacterial infections. Box 2.1 provides examples of homeostatic systems designed to support the life of the person in the most basic sense. Allostasis. The original concept of homeostasis, with the principle that the body attempts to achieve balance around a single optimal level or set point for a given physiologic variable, has been challenged in recent decades. The innate complexity of biological organisms requires that set points be readjusted for different circumstances, i.e., diverse situations necessitate different homeostatic set points, including the anticipation of increased demands. For example, respiratory rate needs to increase when vigorously exercising or when ill with pneumonia to obtain more oxygen. At the same time, when responding to an internal or external environmental challenge, i.e., a stressor, multiple physiologic parameters may have to raise or lower their levels or actions to meet the demands posed by the challenge. Useful changes in one body system, though, may be detrimental to another, especially if prolonged. These changes, however, may ultimately be needed to support the survival of the organism as a whole at that particular point in time. For instance, in shock, when the life of the organism is at risk, blood flow to essential organs, brain and heart, is maintained by reducing perfusion to the kidneys, skin, and gastrointestinal tract. Simply stated, the body is not concerned about digesting dinner or making urine when it is trying to divert resources to a struggling brain and heart. In 1988, Sterling and Iyer introduced the concept of allostasis in recognition of the complexity and variable levels of activity necessary to re-establish or maintain homeostasis. They described allostasis as the ability to successfully adapt to challenges. To survive, an organism must vary all the parameters of its internal milieu and match them appropriately to environmental demands. Like homeostasis, allostasis is a derivation of the Greek words allo, meaning variable or different, and stasis, meaning standing still. Therefore, this term accentuates the role of allostatic systems in maintaining the organism's stability by varying or changing. Allostasis is a dynamic process that supports and helps the body achieve a steady state. In essence, the organism's overall stability is accomplished through change. Allostasis involves intricate regulatory processes orchestrated by the brain. Through these processes, the body's parameters are continuously re-evaluated and readjusted to match resources to the needs dictated by the situation. These parameter readjustments, e.g., of heart rate, blood pressure, or glucose levels, entail altering multiple set points such that the person may be functioning at reduced or elevated levels or rates for numerous physiologic variables. Thus, an individual may have different set points for different circumstances, e.g., when resting versus running or when healthy versus sick. Allostasis comes into play in the complexity of social interactions and in our responses to adverse childhood experiences and low socioeconomic status, SES, exposure to environmental pollutants, and the demands of everyday modern living and working conditions, as well as in critical illness. The concept has garnered broad support in both the physical and the behavioral sciences. It seems especially applicable to subsequent discussions of adaptation and disease. Key points. Contemporary concepts of homeostasis have a long history, reaching back to the ancient Greeks. Homeostasis is a state of equilibrium, of balance within the organism. Homeostatic responses refer to systems whose purpose is specifically to normalize selected physiologic variables. Allostasis is the overall process of adaptive change necessary to maintain survival and well-being. Allostasis may involve altering multiple physiologic variables to match the resources of the body to environmental demands. It helps the body achieve homeostasis. Stress as a concept. Referring to stress as an ambiguous term is an understatement. Its ubiquitous use in everyday parlance is matched by its frequent presence in the health and psychology literature. Stress often is interpreted as a physical, chemical, or emotional factor that produces tension in the body or the mind. He's experiencing a lot of stress. But it also can mean the actual physical and mental state of tension. I feel stressed. Others use the term stress in relation to the response by the body to internal and external demands. Stress can be defined as a real or perceived threat to the balance of homeostasis. The neuroendocrinologist Robert Sapolsky more specifically distinguishes between the stress terminology and defines a stressor as anything that throws the body out of allostatic balance, whereas the stress response is the body's effort to try to restore the balance. To that end, stress is a natural outgrowth of the concept of homeostasis, but is even more applicable to the dynamic concept of allostasis. Sapolsky's definition also underscores an important point. The stress response by the body is meant to be helpful, at least in the short term. However, it becomes damaging when repeatedly activated or when it does not cease. As early as the 1920s, Walter Cannon used the term stress in relation to humans and medicine. Hans Selye, however, often is erroneously credited with being the first person to borrow the term from the fields of engineering and physics and apply it to the human condition. In the 1930s, Selye was experimenting with assorted ovarian and placental hormonal preparations and other tissue extracts and toxic agents. He was injecting these into rats when he serendipitously uncovered a biological basis for stress. Selye was expecting to find different physiologic responses in the rats, depending on which of the various substances was injected. However, to his surprise and disappointment, the same three changes occurred each time. In every animal tested, the cortex of the adrenal gland enlarged, lymphatic organs, thymus, spleen, and lymph nodes, shrank, and bleeding peptic ulcers developed in the stomach and duodenum. When Celli experimented with other noxious stimuli, such as exposing the rats to temperature extremes, surgery, or forced exercise, the same three changes occurred. Any kind of harmful physical stimuli he used produced the same observed physiologic changes. Celli termed the harmful stimuli or causative agents stressors and concluded that the changes observed represented a nonspecific response by the body to any noxious stimulus or demand, a general, stress, response. Because so many different agents caused the same changes, Celli called this process a general adaptation syndrome, GAS, with three components: an alarm reaction, a stage of resistance, and a stage of exhaustion. According to Celli, when confronted by stressors during daily life, individuals move through the first two stages repeatedly and eventually become adapted and used to the stressors. Celli's original conceptualization of the stress response in GAS has been criticized as being too simplistic for the complexities of humans. In particular, evidence suggests the body does not produce the same responses to all types of stressors. Depending on the type and severity of stressor, different patterns of hormone release occur, with more of some substances and less of others being produced and at different speeds and for varying lengths of time. Moreover, Celli's early work in the 1930s concentrated on stimuli of a physical or biological nature. Beginning in the 1970s, researchers began to realize that perception of these stimuli was important to individuals' responses to stress and that responses could be physiologic, as Celli described, as well as behavioral in nature. When stress is generated by extreme psychological or environmental demands, balance is disrupted, and allostatic reactions are initiated to restore balance. The discussion that follows presents the GAS as a reflection of the responses to these diverse stimuli and incorporates much of the knowledge acquired since Celli's early pioneering work. The general adaptation syndrome and allostasis. Components of the GAS can be subdivided into three unique, largely physiologic stages, Table 2.1. Examining the stages separately is the best way to understand the entire GAS. The specific chemicals involved are among those seen today as integral to the broader view of allostatic responses to stress in the maintenance of homeostasis. All will be discussed later in the chapter. Alarm stage. The alarm stage has been called the fight or flight response, derived from Cannon's work, because it provides a surge of energy and physical alterations to either evade or confront danger, Fig 2.1. This stage begins when the hypothalamus, as it monitors the internal and external environment, senses a need to activate the GAS in response to a stimulus, a stressor placing the balance of homeostasis at risk. The stressor might be physical or emotional, positive or negative, arguing with a friend, having an upper respiratory tract infection, running to catch a bus, or winning the lottery. The hypothalamus then secretes corticotropin-releasing hormone, CRH, to activate the sympathetic nervous system, SNS, which in turn also stimulates the adrenal medulla, the inner portion of the adrenal gland, to release the catecholamines, norepinephrine and epinephrine. The increased levels of catecholamines enable the body to rapidly take action to fight or flee the stressor. This series of events is part of the sympathetic adrenal medullary system, originally referred to as the fight or flight response by Walter Cannon. Additionally, the hypothalamus secretes CRH to stimulate the anterior pituitary gland to release adrenocorticotropic hormone, ACTH. ACTH then causes the adrenal cortex, the outer portion of the adrenal gland, to release substantial amounts of the glucocorticoids, specifically cortisol, eliciting its diverse responses. This cascade of effects is termed the hypothalamic pituitary adrenal, HPA, axis. Once the pituitary gland is activated, the alarm stage progresses to the stage of resistance. This coordinated systemic response to stress is illustrated in Fig 2.2. Allostasis is essentially the activation of these stress responses to evoke changes that return the organism to homeostasis. Mediators of allostasis include the aforementioned hormones and neurotransmitters of the HPA axis and the sympathetic adrenal medullary system, e.g., cortisol, epinephrine, and norepinephrine. Various other hormones presented later in this chapter, and also cytokines from the immune system. The alarm stage of the stress response with the release of its various substances is meant to be helpful to the organism in overcoming the stressor. Resistance or adaptation stage. If the alarm stage were to persist, the body would soon suffer undue wear and tear and become subject to permanent damage and even death. To survive, the body must move beyond the alarm stage to a stage of resistance, also called adaptation, supportive of the allostatic return to a state of homeostasis. As the body moves into the stage of resistance, the sympathetic nervous system and adrenal medulla and cortex are functioning at full force to mobilize resources to manage the stressor. The resources include glucose, free fatty acids, and amino acids. Concentrations of these chemicals are elevated through the effects of cortisol and the catecholamines, i.e., epinephrine and norepinephrine. These resources are used for energy and as building blocks, especially the amino acids, for the later growth and repair of the organism after the stress abates. If the stressor is adequately addressed and resolved, the organism returns to its steady state, having reattained allostatic balance. This process described by Celli is clearly a part of the more recently described process of allostasis. However, with the current understanding of allostasis, it is possible that the organism may have to function at a new baseline steady state for different physiologic variables, either higher or lower than the previous set points to achieve adaptation. For instance, the normal partial pressure of carbon dioxide, PCO2, in the blood is 35 to 45 mmHg, and the normal oxygen saturation is greater than 94% in a healthy individual. For someone with chronic obstructive pulmonary disease, a new normal PCO2 value might be 50 to 60 mmHg and the oxygen saturation may be 88% to 90%, while still maintaining a homeostatically normal serum pH. Exhaustion stage. Exhaustion occurs when the body is no longer able to effect a return to homeostasis after prolonged exposure to noxious agents. Celli postulated that when energy resources are completely depleted, death occurs because the organism is no longer able to adapt. He speculated that individuals are born with a given amount of adaptation energy. However, when these adaptive energy stores are depleted, no other resource exists to facilitate recovery. Diseases of adaptation such as hypertension and heart disease occur when the body is continuously taxed by stressors. It is now understood that exhaustion and stress-related disease do not necessarily occur because resources are depleted. Instead, they can occur because the actual stress response itself, with all its various biological mediators, can be harmful when repeatedly activated. Concepts related to allostasis help with understanding the damaging effects of stress. The HPA axis, the sympathetic adrenal medullary system, and other systems, including the immune system, work to help the person adapt to and defend against stressors. Wear and tear on the body and on the brain occurs when these body systems are chronically overactivated or underactivated in their attempts to support an allostatic return to homeostasis. The accumulation of all the various mediators produced by the systems is damaging to tissues over time. This wear and tear on the body and brain is called allostatic load. Allostatic load is basically due to the typical demands that are part of daily life as well as unpredictable events. However, with chronic, unremitting, or excessive demands, allostatic load can become an overload. This allostatic overload reflects the cost to the body's organs and tissues for an allostatic response that is excessive or ineffectively regulated and unable to deactivate. Stressors, gender and developmental influences, and risk factors. Stressors are agents or conditions that are capable of producing stress and endangering homeostasis. They initiate stress response systems to return to a state of allostatic balance. Every day the human organism encounters stressors. These may be external to the individual, e.g., air pollution, radiation, a motor vehicle accident, or internal, e.g., low blood glucose level or a threat to self-esteem. Common general stressors are physical, e.g., extreme hot or cold air temperature, chemical, e.g., auto exhaust, biological, e.g., bacteria and viruses, social, e.g., overcrowding, difficult relationships, information overload, cultural, e.g., behavioral norms, or psychological, e.g., feelings of hopelessness. Stressors of an emotional or mental origin may be present or anticipated, or may involve the recollection of prior traumatic events. Less commonly noted but extremely powerful stressors are psychosocial experiences over which a person may have little or no personal control. Racial and socioeconomic stressors as well as childhood abuse can produce many of the manifestations of stress described in this chapter. Stressors vary in their scope, intensity, and duration. A stressor of less intensity can still have a significant impact if it persists for some time. A glass of water held at arm's length poses little stress initially, but as minutes turn into hours the stress on the body escalates. Even events associated with happiness may serve as stressors: holidays, childbirth, and vacations. Stressors of all types challenge human adaptation. The identification of specific stressors in isolation provides little insight into today's complex global society. A given stressor, depending on its type and duration, may have a particular pattern of hormone and neuropeptide release. Researchers have explored innumerable factors that can indirectly increase or decrease the impact of stressors. It is now generally well accepted that individual personal characteristics, as well as the psychological and circumstantial context of the situation, developmental state of the person, and availability of coping resources, allow for a great deal of variation in the way humans perceive and respond to stressors, and thus the type of stress response produced. The activation of both the sympathetic adrenal medullary system response and the HPA axis occurs with a wide variety of physical, mental, and psychosocial stressors. The HPA axis with its glucocorticoid response, however, seems to be notably prominent and dysregulated in cases of depression and post-traumatic stress disorder, PTSD, and is also active when a person's sense of self is negatively evaluated or the person lacks a sense of control. On the other hand, the sympathetic system is particularly active with anxiety and vigilant states. Furthermore, personality characteristics have been found to be associated with variations in cortisol release and sympathetic adrenal medullary system activation in the stress response. Indeed, the effect of personality on the stress response differs with the situational context. An individual's appraisal of a situation and subsequent reaction is influenced by one's past experiences and conditioning, cultural influences, social expectations, the availability of social support, and a person's genetic and epigenetic profile and gender. Beginning in the early 1970s, researchers started to examine gender differences related to stress, and recent research has continued to expand what is known about these differences. For example, one study in the 1980s examined the differences in performance and stress responses of men and women under controlled laboratory conditions. When subjected to a stressful task, there was a 50% to 100% increase in epinephrine release in men, whereas there was little, if any, increase noted in women, who were also found to perform as well as or better than their male counterparts. Women did have an elevation in epinephrine release in a more real-life stress situation, i.e., an academic examination, but these elevations remained well below those of men. Although some researchers consider these stress response differences between men and women, at least in part, to be related to gender-associated roles and psychological factors, other researchers also attribute these variances to the effects of the sex hormones on the stress response. Data from a recent National Health Interview survey of adults revealed that in every age group, more women than men reported having serious psychological distress. Women are known to have higher prevalence rates of stress and anxiety-related disorders such as depression and PTSD, whereas men show more substance abuse disorders. Estradiol and estrogen may account for some of the gender differences, as the incidence of affective mood disorders appears to become similar for men and women after the age of 55, after menopause. Estradiol may heighten stress reactivity. Accordingly, stressors and traumatic events may have a greater influence if they occur when menstrual cycle estrogen levels are higher for premenopausal women. To date, data regarding gender differences in physiologic responses to stressors are conflicting, with some researchers reporting no differences and others indicating higher or lower levels of cortisol or ACTH in men versus women. The responses seem to depend on the types of stressors assessed. For instance, for adult men, higher cortisol levels were found in studies involving cognitive, harassment, mathematical, and verbal stressors and with social stress testing, whereas higher cortisol levels were found in women compared with men in response to a social interaction stressor. Researchers believe very slight differences in brain architecture due to the effects of sex hormones may result in men and women interpreting and responding to stressors with varied approaches. Developmental stage of life and age also appear to affect the response to stressors. Children exposed to physical and/or psychosocial maltreatment have been shown to have smaller cortices in the prefrontal region of the brain, higher cortisol levels, and elevated levels of inflammation in comparison to other children. Many of these changes persist into adulthood. Additionally, infants whose mothers were depressed or anxious during pregnancy displayed higher cortisol levels in response to stressors. These studies demonstrate the vulnerability to stressors of brain development extending from the prenatal period through adolescence. Risk factors alone are not inherently stressors, but rather conditions or situations that increase the likelihood of encountering or experiencing a stressor. Using a mobile phone to send text messages while driving is a risk factor for having a motor vehicle accident. Running in the dark is a risk factor for falling. And inadequate immunization is a risk factor for certain infectious illnesses. Low SES is a risk factor for exposure to lead and air pollutants in the home and neighborhood. Risk factors also include genetic predisposition and epigenetic factors, as well as adverse early life experiences. By being aware of risk factors, it is possible to decrease the probability of exposure to certain stressors and the associated threat to homeostasis. Key points. Stress is a real or perceived threat to the balance of homeostasis. The stress response is designed to restore balance. Seela's general adaptation syndrome, GAS, theory reflects the view of a nonspecific physiologic response to stress. It incorporates 3 stages indicating the changes in the body's systemic response: alarm, resistance, and exhaustion. Stressors are agents or conditions capable of producing stress. The body's response to stressors is meant to be helpful, at least initially, in terms of mobilizing resources to help manage stressors. Response to a stressor depends on its magnitude and the meaning that the stressor has for an individual. Perception of the stressfulness of a stressor depends on genetic constitution, gender, past experiences and conditioning, and social and cultural influences. Stressors may be external or internal. They may be physical, chemical, biological, sociocultural, or psychological. Individuals may be more vulnerable to the effects of stressors at certain times, including developmental stage of life, the availability of resources, and the effects of other previous or concurrent stressors. Risk factors are conditions or situations that increase the likelihood of encountering or experiencing a stressor. Neurohormonal mediators of stress and adaptation. Numerous hormones and signaling molecules are involved in the daily maintenance of homeostasis through allostatic processes. These mediators are briefly described here, and their roles in allostasis, adaptation, and disease are discussed in later parts of this chapter. A key idea to the understanding of homeostasis is that once the challenges contributing to allostatic load have been resolved, levels of these chemicals should return to their baselines. However, in cases of allostatic overload, pathologies of a physiologic, psychological, or behavioral nature may result. Catecholamines, norepinephrine and epinephrine. Cannon identified that the body's response to threats resulted in the activation of the adrenal medulla and sympathetic nervous system and therefore the release of the catecholamine neurotransmitters. He deemed this the sympathico-adrenal system, and believed it was ultimately responsible for what he termed the fight or flight reaction. The purpose of the fight or flight reaction was the maintenance of the physical and psychological integrity of the organism. The catecholamine neurotransmitters, epinephrine and norepinephrine, play integral roles in allostasis. Release of catecholamines is initiated through the activation of the hypothalamus gland, a collection of nerve centers situated near the third ventricle close to the base of the brain. See Chapter 39. The cerebral cortex and limbic system, including the hippocampus and amygdala, important for memory and emotions, receive information regarding stressors and determine whether or not something is potentially harmful to the organism, i.e., whether it is stressful. They relay the information to the hypothalamus. It should be noted, though, that the stress response, depending on the type of stressor, may occur to some extent even in comatose and sedated individuals. In response to these stressors, the hypothalamus prompts the release of norepinephrine from the sympathetic branch of the autonomic nervous system and locus coeruleus, group of neurons in the brainstem pons, and epinephrine and some norepinephrine from the adrenal medulla. Norepinephrine is released by sympathetic neurons directly into the synaptic clefts near the effector organs and tissues. Additionally, preganglionic fibers from the sympathetic nervous system neurons synapse at the adrenal medulla, stimulating the release of epinephrine and, to a lesser extent, norepinephrine. The adrenal catecholamines are released into the bloodstream and travel to effector organs and tissues, endocrine. These circulating adrenal catecholamines have essentially the same effects as sympathetic nerve stimulation and are often seen as an extension of the sympathetic nervous system. The responses on the part of the sympathetic nervous system and the adrenal medulla may differ according to the stimulus. During situations such as exposure to cold temperatures, the sympathetic nervous system response with norepinephrine production dominates. Emotional distress or acute hypoglycemia, however, causes a greater response from the adrenal medulla, with increased production of epinephrine. The effects of catecholamines are profound. They affect cardiovascular function, control fluid volume by activating the renin-angiotensin aldosterone mechanism, have a role in inflammation and immunity, and affect metabolism, and they are associated with attentiveness, arousal, and memory formation in the central nervous system, CNS. Norepinephrine is the primary constrictor of smooth muscle in blood vessels. It therefore regulates blood flow through tissues and its distribution through the organs, as well as, importantly, maintenance of blood pressure. It also reduces gastric secretion, inhibits insulin secretion, and innervates the iris and ciliary muscles of the eyes, thereby dilating the pupils and increasing night and far vision. Epinephrine enhances myocardial contractility and increases heart rate and venous return to the heart, thus increasing cardiac output. It additionally relaxes bronchial smooth muscle, thereby dilating the airways to enable better oxygenation. Epinephrine also increases glycogenolysis, the release of glucose from the liver, and inhibits insulin secretion, further elevating blood glucose levels. In the brain, the increased blood flow and availability of glucose lead to augmentations in mental attention and alertness. Epinephrine and norepinephrine also exert immune system effects by influencing the production of cytokines by immune and adipose cells. The effects of the catecholamines are summarized briefly in Table 2.2. For more detail, see Chapter 43. Adrenocortical steroids, cortisol and aldosterone. Among the most versatile hormones in the human body, glucocorticoids have regulatory roles in maintaining fluid volume, metabolism, immunity, inflammatory responses, and brain function. Table 2.3. Glucocorticoids are lipid-soluble hormones, allowing them to pass through cell membranes to bind with receptors in the cytosol or nucleus and initiate changes in cellular activities. Practically every body tissue has intracellular glucocorticoid receptors. As opposed to the catecholamines, the onset of their effects is slower, but the duration of action is longer. The glucocorticoids are so named because of their significant role in glucose metabolism. The primary glucocorticoid, cortisol, is secreted by the adrenal cortex in response to ACTH from the anterior pituitary. Release of ACTH is itself affected by another releasing hormone, CRH, from the hypothalamus. Negative feedback loops help to maintain cortisol level within a normal range. Cortisol binds to receptors on the hypothalamus and anterior pituitary gland to suppress CRH and ACTH release in a negative feedback loop. The actions of the HPA axis and catecholamines may synergize or antagonize each other. Catecholamines facilitate the release of ACTH, thereby helping to maintain the function of the HPA axis and release of cortisol. Glucocorticoids promote adrenal medulla synthesis of epinephrine through control of the major enzyme phenylethanolamine N-methyltransferase, PNMT. Glucocorticoids also support the actions of the catecholamines in the maintenance of normal blood pressure and cardiac output. In skeletal muscle, catecholamines antagonize the catabolic glucocorticoid effects by impeding the breakdown of somatic protein. Together, the catecholamines and glucocorticoids facilitate the brain's development of memory, which is especially important when hazardous circumstances have occurred. The metabolic effects of cortisol are significant. Cortisol affects protein metabolism. It has an anabolic effect leading to increased rates of protein synthesis in the liver. However, it has a catabolic effect in muscle, lymphoid, and adipose tissues and on skin and bone. This protein breakdown produces increased levels of circulating amino acids. The resulting pool of amino acids from catabolized proteins ensures their availability for the liver. Cortisol then stimulates gluconeogenesis in the liver in a 6-fold to 10-fold increase in the rate of amino acid conversion to ketoacids and glucose. The catabolism of adipose tissue releases free fatty acids and glycerol that also can be used for gluconeogenesis and to create ketoacids for fuel. Gluconeogenesis ensures an adequate supply of glucose for body tissues in general, but nerve cells have priority. Cortisol may act to preserve available glucose for brain nerve cell use by limiting the uptake and oxidation of glucose by other cells in the body. Cortisol also promotes appetite and food-seeking behaviors. Glucocorticoids are known for their significant role in the control of the immune response. They suppress the acute phase response to infection and inflammation, helping to curtail overactivity. This is accomplished by inhibiting the production of select immune cytokines, signaling molecules, by increasing the production of other cytokines, and in some cases by directly inhibiting the proliferation and activation of specific immune system cells. At the same time, when the acute stress of tissue injury or infection occurs, the resulting release of glucocorticoids and catecholamines assists the movement of the necessary immune cells to the affected location. However, with prolonged stress and chronic elevation in the levels of glucocorticoids, desensitization and downregulation. Decrease of glucocorticoid receptors may occur on some immune cells, eventually resulting in fewer anti-inflammatory effects over time. In fact, continued stress can even result in pro-inflammatory effects. Thus, the relationship of the immune system to stress is quite multifaceted, and our understanding of it is evolving. Aldosterone is the primary mineralocorticoid steroid hormone secreted by the adrenal cortex. Stimulation of the sympathetic nervous system activates the renin-angiotensin system, and the release of aldosterone is the final chemical outcome. The specific stressor of fluid volume depletion also activates the release of renin, similarly initiating the renin-angiotensin system. The primary effect of aldosterone, once bound to receptors in the kidney's distal tubules and collecting ducts, is reabsorption of sodium and an increase in the excretion of potassium. Because of osmotic force, water tends to follow sodium. Therefore, enhanced reabsorption of sodium leads to increased extracellular fluid volume and increased blood pressure. Endogenous glucocorticoids have a small amount of mineralocorticoid effect, but the greatest effect on circulating volume is through aldosterone. Additionally, angiotensin II, whose formation stimulates aldosterone release, is a potent vasoconstrictor. This chemical mediator provides support for the catecholamine-induced increase in blood pressure. Endorphins, enkephalins, and immune cytokines. Stress naturally activates the inhibition of pain through the release of small peptides called endorphins and enkephalins. First discovered in 1975, endorphins and enkephalins are endogenous opioids that are produced within the CNS and released in response to stressors, by certain foods, most notably chocolate, by laughter, and from massage or acupuncture. The term endorphin comes from endogenous and morphine. Like the opiate drug morphine, endorphins raise the pain threshold, reduce pain, and produce sedation and euphoria. During acute stress, the endogenous opioids also may attenuate the stress response, especially activation of the SNS by CRH. Some immune cells, B and T lymphocytes, granulocytes, macrophages, and monocytes, also produce several types of endorphins that are released in response to stressors, CRH, anti-inflammatory cytokines, and catecholamines. Opioid receptors have been identified on immune cells, and when activated they modulate both immune cell proliferation and immune cell activity. On the other hand, in the presence of acute or chronic stress, activated immune cells, mast cells, neutrophils, macrophages, and T lymphocytes can release pro-inflammatory cytokines that enhance pain. Pain is a classic manifestation of the inflammatory response, Chapter 9. Thus, the central and peripheral nervous systems and the immune system maintain complex patterns of interactions with pain pathways as part of the allostatic mechanism to return to homeostasis. Another example of the interaction between stress, the nervous system, and the immune system is interleukin-1, IL-1, one of the cytokines secreted by macrophages and other immune cells. It is capable of affecting the production of CRH by the hypothalamus. Leukocytes are also capable of producing some of the other hormones, such as ACTH, that are involved in the signaling system. Some researchers propose that stressors of relatively short duration, e.g., less than 2 hours, could augment facets of immune function, including the emigration of immune cells from the lymphoid tissues, e.g., the spleen, to the skin and peripheral components of the vascular system. On the other hand, numerous studies over the years have shown that severe and persistent psychological stress can down-regulate or suppress immune functioning through innumerable and elaborate mechanisms. Immune system suppression caused by severe or persistent stress represents a direct link between stress and illness. Expanded understanding of the interrelationships between the nervous, endocrine, and immune systems holds great promise in the identification of new therapeutic interventions. Sex hormones. Estrogen, testosterone, and dehydroepiandrosterone. As noted previously, women and men often have different stress responses, and this may be partially attributable to the influences of the sex hormones and their interactions with the mediators of allostasis. Excessive stress appears, in general, to inhibit female reproduction and affect premenstrual symptoms. Cortisol exerts inhibiting effects on the female reproductive system by suppressing release of gonadotropin-releasing hormone, luteinizing hormone, estradiol, and progesterone, whereas estradiol normally down-regulates glucocorticoid receptor binding in the brain and alters regulatory feedback control. Androgens, such as testosterone and dehydroepiandrosterone, DHEA, also may inhibit the effects of glucocorticoids. Androgens oppose the catabolic effects of glucocorticoids on bone and the impact of glucocorticoids on lymphoid tissues, inflammatory cytokines, and leukocytes. DHEA interacts with numerous neurotransmitters in the brain, counteracting the depressive tendencies often noted with glucocorticoids. Testosterone also appears to have antidepressant and anti-anxiety effects as it elevates mood. Numerous stressful stimuli, such as illness, surgery, strenuous physical exercise, heart failure, and stressful academic programs, result in significant reductions in circulating testosterone levels. In combination with another hormone, vasopressin, testosterone enhances blood pressure and heart rate reactivity and augments the fight or flight response. In contrast, the hormone oxytocin, whose impact is modulated by estrogen, and the endogenous opioids are thought to produce a calming effect during times of stress, resulting in the notion that women may have a tend and befriend response rather than a fight or flight response in some situations. Growth hormone, prolactin, and oxytocin. Growth hormone, somatotropin, is released from the anterior pituitary gland and affects protein, lipid, and carbohydrate metabolism. It has anabolic effects, increasing protein synthesis and bone and muscle mass growth. It also increases fat mobilization, lipolysis, while decreasing the rate of carbohydrate utilization by peripheral tissues. Growth hormone is normally secreted in a cyclic basal pattern, primarily at night, and changes with developmental stage. Growth hormone secretion is highest during adolescence and then gradually declines during adulthood. Serum levels of growth hormone also increase acutely after a variety of intensely stressful physical or psychological stimuli, such as strenuous exercise or extreme fear. Growth hormone appears to enhance immune function. However, continued activation of the stress response eventually results in the decreased secretion of growth hormone, accounting for stunted growth in children experiencing prolonged chronic stress. Prolactin is similar in structure to growth hormone and is secreted from the anterior pituitary gland in response to stress, sexual activity, pregnancy, and suckling, even in men, and breastfeeding. It suppresses ovulation. Numerous tissues have receptors for prolactin in addition to the breast, including the kidneys, liver, and adrenal glands. Lymphocytes also have prolactin receptors, suggesting a role for prolactin in immune regulation. A significant increase in the level of growth hormone or prolactin tends to require more intense stimuli than the stress that increases the concentrations of catecholamines and glucocorticoids. Oxytocin is produced during childbirth, lactation, and sexual behavior, in both genders, and has been associated with promoting bonding and social attachment. Oxytocin is thought to moderate the stress response and have a calming effect, with reductions in HPA and sympathetic activation and reduced perceived anxiety. In an intriguing study, researchers found that pre-teenage girls who spoke with their mothers on the phone immediately after a laboratory social stressor had higher levels of urinary oxytocin and lower levels of salivary cortisol than did those who merely texted their mothers. Hearing the mother's voice appeared important to the release of the oxytocin and buffered the stress response. Oxytocin also may have some analgesic effects. It is synthesized by the hypothalamus and secreted by the posterior pituitary gland and other brain regions. Oxytocin is believed to have stronger effects in females in comparison to males because of the interaction of estrogen and oxytocin. Through interactions of the primary stress hormones, catecholamines and glucocorticoids, as well as numerous other mediating influences, the allostatic process needed to sustain the human organism is achieved. In some cases, these stress-related hormones have similar and synergistic effects, and in others they work in opposition. This state of counterbalancing helps to facilitate allostasis, ideally returning the human organism back toward homeostasis. Key points. Modern views of allostatic maintenance of homeostasis in the face of stress are primarily derived from an understanding of negative feedback, as well as the roles of the sympathetic nervous system catecholamines and the glucocorticoid cortisol. The primary role of the sympathetic nervous system, SNS, is appraisal of a stressful stimulus and release of norepinephrine. Norepinephrine released from sympathetic nerve endings increases heart rate and contractility, constricts blood vessels to decrease blood flow to less essential tissues and organs and raise blood pressure, reduces gastrointestinal motility and gastric acid secretion, dilates the pupils, and inhibits insulin secretion. Stress stimulates sympathetic activation of the adrenal medulla to release epinephrine. Epinephrine's actions are similar to norepinephrine and are particularly important for increasing cardiac performance, increased heart rate, contractility, and cardiac output, promoting the release of glucose from the liver and enhancing bronchodilation. Cortisol, from the adrenal cortex, has widespread effects on numerous tissues that are both synergistic and antagonistic with catecholamines and has an anti-inflammatory role. Aldosterone promotes fluid volume expansion and increases blood pressure. Endorphins and enkephalins are released by the CNS in response to painful stressors, leading to decreased perception of pain and increased sedation and euphoria. Immune cells in the periphery also contribute to pain modulation. Immune cells respond to the hormones released by the HPA axis and sympathetic nervous system. They also release cytokines that in turn affect the functioning of these stress systems. Sex hormones and differential release of growth hormone, Prolactin, and Oxytocin produce effects on the stress response that may differ between genders. Adaptation, coping, and illness. Although much has been learned about the dynamic biological systems and human-environmental interactions involved, stress is personal in that individual stress responses change with time and circumstances. Indeed, the effects of stress on each individual are influenced by genetics, SES, environmental context, perception, developmental history, prior susceptibilities, pre-existing health status, and individual coping abilities. Clearly, the maintenance of homeostasis requires the human organism to routinely initiate allostatic responses to the stressors of daily life, as well as to the less frequent severe assaults on the integrity of the body and the mind, responsible for allostatic load. Systemically, allostasis may be seen as beginning with some degree of the alarm stage, fight or flight activation, and ideally moving to an effective resolution through adaptation, ultimately culminating in a return to homeostasis. The prolonged effects of allostatic overload, the long-term wear and tear costs of adaptation efforts, provide a conceptual foundation for examining the long-term consequences of stress on health. What Selye called diseases of adaptation are the outcomes of allostatic overload. Adaptation, coping, and resilience. Adaptation broadly refers to the biopsychosocial process of adjusting physiology, morphology, and behavior in response to new or altered circumstances, internal and external in origin, in the physical and social environment. Related to adaptation is the term resilience. Resilience is the ability to withstand threats to stability and is a measure of the capacity to adapt to challenges. It has been described as the ability to bend without breaking in the face of environmental or psychological perturbations. Because allostasis is a process of attaining and maintaining stability through change that leads to a state of adaptation, the terms adaptation and resilience have been intertwined with allostasis. Resilience is the capacity to adapt to stress and adversity, thereby preventing the development of disease and mitigating the effects of allostatic load. It means attaining a positive outcome when encountering adversity. Resilience can be affected by multiple factors, some of which include genetics, epigenetic changes resulting from early life exposure to traumatic events, the availability of social support and coping mechanisms, a sense of optimism and control, prior learning, and lifestyle factors such as physical activity, exercise, diet and nutrition, and adequate sleep. Resilience is influenced by the chemical allostatic mediators that promote adaptation such as cortisol, and some neural proteins such as brain-derived neurotrophic factor, BDNF, which may be necessary for brain plasticity. Maladaptation, a less frequently used term, refers to ineffective, inadequate, or inappropriate change in response to new or altered circumstances. Coping is another term used and is most often seen as a behavioral adaptive response to a stressor. Coping mechanisms are typically culturally based, and consequently vary with the individual within the parameters of what is acceptable to the given culture. The coping behavior is usually dictated by the specific stressor, thus it fluctuates with the circumstances, but individuals typically embrace a specific repertoire of coping behaviors. These behavioral adaptations allow an individual or a group to withstand successfully the stressful experience or the stress response generated by the experience. A coping strategy can be considered effective or functional if it helps resolve either the situation or the feelings. In some cases, such as exercise, mindfulness meditation, and seeking social support, the coping method can promote health. A coping strategy is considered ineffective or dysfunctional if it does not achieve the desired goal. Coping that achieves unintended goals is considered dysfunctional or maladaptive. Adaptation may result in the adoption of less than desirable coping behaviors, such as excessive eating or alcohol consumption, smoking, or other types of substance abuse and avoidance behaviors. Unfortunately, these dysfunctional coping behaviors can ultimately be damaging to overall health. Smoking and overeating contribute to atherosclerosis, the underlying pathophysiology of coronary artery disease and a risk factor for hypertension. Excess weight accumulated through overeating is a contributing factor for type 2 diabetes mellitus and metabolic syndrome. Although coping is customarily interpreted as behavioral adaptation only, the terms coping and adapting often are used interchangeably. Perception and expectations of the stressor can affect its interpretation, and therefore the behavior evoked by it. Perceptions can be related to uncertainty about the meaning of the stressor. Consider the stressor of undue noise. The bang of a car backfiring could also be the sound of a gun being fired. Depending on the environment and circumstances, one or the other etiology would be more expected, dictating different adaptive responses. The term distress describes the experience of perceiving an inability to cope with a physiological or psychological stressor. This distress further activates the release of catecholamines from the adrenal gland medulla and glucocorticoids through the HPA axis, escalating levels of circulating mediators, and may exacerbate existing allostatic load and pre-existing pathophysiologic conditions. For instance, the person with asthma who is experiencing an episode of acute shortness of breath is likely to become even more short of breath when discovering an inhaler is not readily available. Adaptation to a stressor can occur in several ways. Loud noise is a known stressor. Yet people who live close to busy airports often reach a point at which they barely notice the noise of airplanes flying over their homes. They become habituated to the stressor, loud noise. One important way to habituate to a stressor is to manipulate, or train, the hypothalamus to react less forcefully to a perceived threat or stressor. Repeatedly ignoring a specific stressor prevents the inappropriate triggering of the gas. The result is a more acceptable level of stress response. Techniques that accomplish this desensitization change the predominant brain waves of the individual from beta to alpha waves, which are slower and more normal. Biofeedback, visualization, and meditation are examples of therapies that use this principle. Practicing these techniques for 20 to 30 minutes daily can enhance the ability to alter how a stressor is perceived and modulate the stress response. These techniques have documented efficacy in enhancing immune function. Desensitization methods have been found to be beneficial for common stress-related conditions, such as migraine headache, chronic back pain, and hypertension. Allostatic overload and illness. When adaptation mechanisms are inadequate or the total amount of allostatic load is excessive, overwhelming allostasis capacities, the result is allostatic overload. There are several ways in which allostatic load can accumulate in an individual. 1. Repeated exposures to multiple stressors. 2. Inability to habituate or adapt to the stressor. 3. Unnecessarily prolonged stress response or stress response that continues after the stressor is removed. And 4. Inadequate response to the stressor that causes other stress response mediators to attempt to compensate. Homeostasis, the steady state that previously existed, cannot be attained. Instead, allostatic overload occurs, and the resulting maladaptation can be reflected in a range of pathophysiologic states that span the traditional boundaries of healthcare, from psychiatric and endocrine disorders to inflammatory disease. Hair loss, emotional tension, burnout, mouth sores, insomnia, asthma, heart palpitations, neuromuscular movement disorders, tics, tension headaches, muscle contraction backaches, digestive disorders, and irritable bladder are just a few of the common disorders that can be caused by or worsened by stress. Reproductive disorders such as menstrual irregularity in women and male impotence also have been linked with the effects of allostatic overload. Box 2.2 summarizes some of the physiologic and psychological effects of excessive stress. Fig 2.3 depicts the multiple body organs and systems in which the effects of insufficient or overactive stress responses may be seen. The chemical mediators of stress have a strong physiologic basis for the role they play in contributing to illness. Cortisol being released from the adrenal cortex supports Sela's stage of resistance or adaptation, but may also be accountable for pathologic changes. The same can be said of the catecholamines and the other chemical mediators, e.g., immune cytokines. Because these blood-borne chemicals have such broad effects systemically, the impact of excessive or inadequate amounts is understandably wide-reaching. In some cases, the relationships have been well substantiated by research. In others, they are hypothesized based upon knowledge of the effects of these chemicals. The relationship between excessive catecholamine levels and what historically have been called stress-related illnesses has often been associated with cardiovascular pathologies such as hypertension, stroke, and myocardial infarction. Abdominal fat cells are well supplied with cortisol receptors, and excessive secretion of cortisol results in the collection of fat in this area. When this fat is released into the bloodstream, the resulting increase in the levels of circulating free fatty acids plays a role in cardiovascular risk. Additionally, repeated or prolonged elevation of blood pressure, especially in combination with the metabolic effects of elevated cortisol and catecholamine levels, promotes the development of atherosclerosis in, ultimately, many cardiovascular pathologies. Not only do catecholamines contribute to the development of atherosclerosis and hypertension, they also increase the risk of developing cardiac dysrhythmias and sudden cardiac death, and even stress-induced cardiomyopathy. They increase platelet activity, resulting in clot formation, and elevate serum lipid levels, significant factors in the pathogenesis of myocardial infarction. A growing body of evidence further suggests that inflammation may mediate a link between stress and cardiovascular disease. Stress has been associated with the production of pro-inflammatory cytokines such as IL-1, IL-6, and tumor necrosis factor, TNF. These cytokines can trigger the production of C-reactive protein, CRP, a cytokine associated with cardiovascular disease. The field of psychoneuroimmunology has provided substantive evidence of the roles of the stress hormones in the brain. In the central nervous system, specifically the brain, the mediators of adaptation facilitate learning, memory, and neuroendocrine and autonomic regulation. This heightened memory, at least in the short term, allows the individual to be more aware of the potential stressor in the future. Chronic overactivity or underactivity, however, may result in atrophy of some nerve cells, especially in the hippocampus, impairing memory, whereas others have been found to hypertrophy, especially in the amygdala, and undergo remodeling, resulting in an increase in fear, anxiety, and other mood disorders. In essence, allostatic overload results in altered and impaired cognitive function. Some evidence suggests that inflammation associated with allostatic overload may play a role in learning and memory impairment. For instance, elevated levels of pro-inflammatory cytokines, such as IL-1 and IL-6, markers of inflammation associated with stress, have been linked with memory loss, cognitive decline, and the development of Alzheimer's disease. Emerging research indicates that males and females may show different patterns of brain structure remodeling in response to chronic stress. Estrogen may exert neuroprotective effects. Stress hormones have been found to be elevated and dysregulated in major depressive illness. Increased cortisol secretion, decreased testosterone levels in men and women, and increased levels of growth hormone and pro-inflammatory cytokines have been documented in major depressive illness. Depression is common with chronic diseases such as fibromyalgia and multiple sclerosis, and the elevated cortisol levels associated with allostatic overload may be significant to the progression of some of the diseases. Another condition, PTSD, also appears to be associated with heightened sympathetic adrenal medullary responses as well as alterations in the HPA axis. Evidence suggests cortisol and norepinephrine help promote long-term memory consolidation and retention of traumatic and fearful events. However, administration of beta blockers such as propranolol that interfere with the effects of norepinephrine has been shown to reduce the incidence of PTSD symptoms in many cases. Allostatic mediators activate and maintain energy reserves, which are initially meant to be helpful in managing stressors. Nonetheless, obesity, especially abdominal obesity, diabetes, atherosclerosis, metabolic syndrome, osteoporosis and bone demineralization, and other diseases, as well as accelerated aging, are associated with their chronic activation. The food-seeking behavior initiated by cortisol is beneficial in the short term, but when cortisol levels are increased by chronic stress of either a physiologic or a psychological origin, this adaptation gone awry results in obesity. Obesity is a risk factor for decreased effectiveness of glucose transport into the cells, insulin resistance, the pathophysiologic basis for type 2 diabetes. Elevated cortisol levels also directly increase insulin resistance. Additionally, obesity is associated with the production of pro-inflammatory cytokines such as TNF-alpha, IL-1, and IL-6, which also have been connected to diabetes. In acute stress, activation of the immune system allows for the coordinated defense of the body from damage. At first, leukocytosis and immune function, including phagocytosis and antibody production, may be enhanced to protect the body from foreign invaders, e.g., bacteria and viruses, but then is followed quickly by immunosuppression. Chronic activation of the stress mediators produces immunosuppression and increases the risk of infection and has been implicated in the development of autoimmune diseases and some cancers. Such overactivation also prolongs existing infections and the development of secondary infections. Research supports the hypothesis that physical and emotional stress and dysfunctional coping mechanisms impair both antibody and T-cell mediated responses to viruses and antiviral and antibacterial vaccines. Stressors of more than 1 month's duration have been found to be the greatest predictors of the development of colds. Cumulated evidence, in both human and animal models, supports the premise that stress-induced dysregulation of the cellular and humoral arms of the immune system increases risk of infectious disease. Stress has been found by numerous studies to accelerate the progression of HIV infection. Immune dysregulation can also include the excessive production of cytokines that promote the inflammatory response. Both physical and psychological stressors have been found to accomplish this, sensitizing the overall inflammatory response so that subsequent activations are markedly increased. Early life stress such as low SES and childhood abuse and neglect have been associated with signs of inflammation, including elevated levels of IL-6, TNF-alpha, and CRP later in adulthood and older age. Inflammation may partially explain the relationship between childhood stress and some later life illness conditions, including cardiovascular disease, type 2 diabetes, and some forms of cancers. Many other diseases also are associated with chronic inflammation: Alzheimer's disease, chronic inflammatory bowel disease, depression, PTSD, osteoporosis, rheumatoid arthritis, asthma, and periodontal disease, to name but a few. Wound healing also is impaired by multiple mediators of stress in excessive amounts. Epigenetics is emerging as a new area of study, with epigenetic changes providing a link between some types of stressors and disease pathologies. Epigenetics refers to modifications in gene activity that do not entail altering the basic DNA sequence. These modifications may involve chemical tags or markers on the DNA that can turn a gene on or off. Examples of the mechanisms include DNA methylation, histone modification, and microribonucleic acid, mRNA, gene expression regulation. For instance, adverse childhood events have been associated with DNA methylation in adults and consequent production of IL-6. It is possible that epigenetic changes acquired as a result of early life adverse experiences such as famine or poor maternal attachment and care may make the person susceptible later as an adult to respond to stressors in ways that are adaptive in a threatening environment but maladaptive in a more friendly situation. As an example, a person prone to responding to stressors with a heightened sense of vigilance and arousal may find this response helpful in the dangerous situation, but it may lead to anxiety and depression when repeatedly used in a safer environment. Another new area of stress research attracting attention pertains to telomeres and telomerase. Telomeres are the tail ends of chromosomes that get shaved down with repeated cell division, and thus older cells tend to have shorter telomeres than younger ones. These cells with shortened telomeres are more susceptible to death. Telomeres are both markers and mechanisms of biological aging and may serve as a means of measuring a person's total accumulated exposure to stressors. Chronic stress related to caregiving, lower SES, and number of childhood adversities has been linked with shorter telomere length. Depression and anxiety and several other diseases, e.g., cardiovascular disease, diabetes, and cancer, also have been associated with shortened telomeres. This research suggests a mechanism by which stress may contribute to cell death and disease, because telomere shortening may be connected to some extent to elevated cortisol, catecholamine, and inflammatory cytokine levels produced as part of the stress response. On the other hand, telomerase is an enzyme capable of lengthening telomeres and is inversely related to perceptions of stress. In one study, 30 men and women took part in a 3-month meditation retreat program aimed at reducing psychological distress. By the end of the study period, the participants had significantly higher telomerase activity levels in comparison to waitlist controls. In another study, adherence to comprehensive lifestyle changes involving stress management, aerobic exercise, nutrition, and social support were associated with greater telomere length at 5 years after study initiation in men with prostate cancer in comparison to a control group. More research is needed to understand the relationships among telomeres, telomerase, stress, stress-related diseases, and coping methods, as well as aging and longevity. Key points. Adaptation, or allostasis, is a network of biopsychosocial processes of responding to a stressor with the goal of re-establishing homeostasis. Coping mechanisms are usually seen as behavioral adaptations to stress, but are often used interchangeably with adaptation. They can contribute to resilience. The wear and tear effect of adaptation on the body and mind is the allostatic load. It occurs as mediators produced by the stress response systems accumulate and contribute to tissue damage over time. Allostatic load reflects the cumulative costs of adaptation. A number of disorders are thought to be related to excessive stress or inappropriate stress responses, allostatic overload. These are a result of the dysregulation and excessive use of the mechanisms and mediators involved in the stress response. Summary: homeostasis is the state of balance of the body's biopsychosocial systems. Stressors evoke a stress response and initiate adaptive efforts, an allostatic process, designed to return to this steady state. The response to stressors is affected by a wide variety of factors. Recently, there has been an increase in knowledge regarding the complex interactions of the HPA axis, the SNS, the immune system, genetics and epigenetics, and the chemical mediators of the stress response. Excessive or prolonged stress and overactivity or underactivity of associated chemical mediators produce disproportionate responses in the body, a condition of allostatic overload known as stress-induced illness. As humans strive to adapt to the constant changes of modern life, the study of stress and stress-related disease has become vital to public health and contributes to the development of increasingly sophisticated models of health and illness.